I've got Dr. David Berkoff, who's a very passionate musculoskeletal ultrasound instructor. At this point, what I'm going to do is I'm going to let Dr. Berkoff kind of introduce himself, his background. And Dr. Berkoff, if you don't mind, I'd like to start the meeting off with kind of let people know what got you interested in ultrasound and a little bit of how you use it day to day, and then we'll get started with the presentation.
Sure. So for those of you who don't know me or we haven't met, my name is David Berkoff. I am initially emergency medicine trained and then sports med fellowship trained. I was at Duke for a long time and moved over to University of North Carolina a few years ago. My interest in ultrasound began probably in the late 90s in emergency medicine, which was one of the early adopter fields for bedside and point-of-care ultrasound. And as I moved from emergency medicine into sports medicine and saw this new technology back then kind of emerging into this field, I became involved on this end. I use it now as a regular part of my practice and a fairly outspoken, firm believer that this needs to be a part of what we all do, both for diagnosis and procedurally. My practice is very heavy ultrasound, probably a little more of a slant towards procedural. I work in an orthopedics group and do a lot of the ultrasound-guided procedures that once went to radiology and elsewhere. And we use ultrasound in our daily practice for new patient evaluations, evaluating, diagnosing, and treating a whole host of musculoskeletal problems.
Great, fantastic. So I went ahead and made you the presenter, Dr. Berkoff. I want to have you go ahead and share the PowerPoint feature on your computer, and then we will go ahead and get started with the ankle and foot presentation. You guys are actually in for a pleasant treat today because at first we talked about only doing procedural notes for today and only speaking on needle treatments, but the foot and ankle can be a tricky monster, and there's a lot going on anatomically. So Dr. Berkoff actually felt it would be far more relevant and far more valuable to be adding a few more diagnostic level slides too. So we'll all want to thank him for sharing his content here today. Without further delay, I'm going to go ahead and turn control over to Dr. Berkoff. Thank you.
All right, thanks, Dan. And as the webinar format, as Dan said, it's a little more difficult to be engaging on a point-to-point level because your questions will have to be pushed off till the end because there's so many different people chiming in at different times. So just keep sending them to Dan and we will answer them at the end instead of during. So we're just going to kind of work through the foot and ankle with how to scan some basics of regular and abnormal anatomy, and then how we go about, or I go about, some of the basic ankle and foot injections. So the injection concept is the most important when we talk about how do we inject, and this is the one concept that's kind of the only point you need to remember from today, which is, are we doing an in-plane or an out-of-plane injection? So in-plane, or what I call a long-axis injection, and an out-of-plane, or what I call a short-axis injection. And when we look at those, this is going to be how we decide what we're looking at and how we're going to get a needle to where we're going. And a lot of the foot and ankle injections are very superficial injections, so we have to be cognizant of not only where we're going, but what we're going through to get there. And when we look at this slide, and this is a slide I put together in most of our injection talks, which helps to understand the concept of volume averaging and the idea of what is a short axis or out-of-plane injection and a long axis or an in-plane injection. Can you see my pointer, Dan?
Yes, see that moving loud and clear.
So when we do a short axis or out-of-plane injection, we are coming in down from this way across the plane of the probe. And when we do this, all we're going to see is the tip of the needle. Very different than an in-plane or long-axis injection, whereas the needle passes underneath the probe, we're going to get to see the entire length of the needle. I find early on it's often more comforting to do a long-axis or in-plane injection because you get to see the whole needle as it comes down to the point here. However, for a lot of the structures that we're going to be looking at injecting today in the foot and ankle, we're looking at a round tendon with a tendon sheath. So the idea of being very precise, we need to get our needle tip right here next to the tendon, but not in it, but still within this sheath. often our out-of-plane or short-axis injection will be a little bit more accurate. And the reason for it is this idea of volume averaging. So as these beams come down from the transducer, hit our structure and bounce back, in this long axis of the probe, each beam that comes down comes back. So if I put the tip of my needle here, this is where the tip of my needle is. It's a very precise injection, a little harder maybe to master only because you only get to see the tip of your needle. This is in contrast to the long axis injection, where you have this wide beam that's averaged down to the one picture we see on our screen. So the beam is taking all of this image and combining it to a single, one-dimensional view. So as you can see, I've put white dots kind of in a multitude of different places. All these needles will show up on your screen, but you can see we can hit this tendon sheath in a whole bunch of different areas just based on where we are within this plane. So particularly on a long axis view of a tendon that may be curving, sometimes what looks like we're in the tendon, we may actually be a little left or right. So the idea of long versus short axis injections are going to be an important point to today's lecture, but just in general for ultrasound-guided injections. And we start with the Achilles tendon, and these are very easy structures to scan because they're superficial. Most of the slides, or all of the slides we have today, somewhere on the slide, usually in the upper corner, you're going to see a picture, an anatomic picture with the probe. This probe position is going to reflect what we're looking at on the ultrasound. So we have an anatomic view as well as this broken down 3D animation view where you can see our probe. Here's the Achilles tendon, the calcaneus, and you can see our probe is catching part of the calcaneus and the Achilles tendon as it comes off. And here's our Achilles tendon by ultrasound. Here's our calcaneus. This is skin up here, soft tissue, and Dan has this great 3D view which helps us to look at the different structures. We have Kager's fat, Achilles tendon. We have our retrocalcaneal bursa down here. We have another little small bursa that sits on top, which is less significant clinically, and our Achilles tendon. And one important thing to note with the Achilles tendon, and we see this in other areas as well, our Achilles tendon comes down, but as it inserts to the calcaneus, it has to turn a little bit. And for those of you who have done any musculoskeletal ultrasound before, you know that when we're looking for tears or pathology, it's often dark areas. And so the question is, why is there a dark area on this part of the tendon? And this is that function of the tendon making the turn to connect on the calcaneus, or anisotropy. And anisotropy is a function of ultrasound where the beam is bouncing off and heading away from the probe. And if this is something that people don't understand, it's hard without getting visual feedback if you all understand this concept. But we can talk about this a little bit afterwards. But just to keep in mind, sometimes a little tilt of the probe here to make sure that this area here is in fact just normal tendon as it turns to insert is going to be real important. As we move on to the Achilles tendon, so again, as we scan this tendon, it's going to be important to scan this forward and back, so top to bottom, as well as turning our probe and scanning it in the short axis all the way from cranial to caudal. And this is because it's a round structure that's thick. It's not a single plane. We want to get all of the view. We wanted to put in some pathology for you. So here's a great scan. Here's an MRI with an Achilles tendon tear. And let me see if I can get this to play. This is just kind of scanning through the MRI. That one's not going to play, but it's going to scan through the tear visualized on ultrasound. And then you look over here, you can see, if you remember that organized structure that we had on the Achilles tendon on our normal views, here, when we look at a torn Achilles tendon, we have this disrupted irregular complex here where the proximal and distal ends are no longer touching. So again, as we scan further through other Achilles, we're scanning long to the Achilles, up and down, left and right. Here's an Achilles tendon. Now remember how organized this looks here, but we have this big blacked out area down here. Different than that little black area I showed you at the insertion. This is a large area within the tendon that's an undersurface tear just as it comes into the insertion. So this is an undersurface tear of the Achilles tendon. This is real different than this black area down here, which is deep to the Achilles tendon. This is the retrocalcaneal bursa. Here's our tendon up here. Our view's shrunk down, so Achilles tendon, left to right across the top, inserting on the Achilles tendon, and this, with all this hypervascularity, is a retrocalcaneal bursitis. Easy to see by ultrasound. When we look at other Achilles tendon pathology, this is kind of a progression. They're not necessarily the exact same patient, but you can see how we had that nice linear structure of Achilles tendon before. Oh, no. This is an Achilles that's starting to swell. It's got a big swollen Achilles tendon with some hyper and hypoechoic areas. You scan later on, this is a runner who had chronic Achilles pain for years. You start to see these multiple small calcific densities that are forming within the big thickened Achilles tendon. Then further on down the road, you see this one with an established large calcific deposit within the Achilles tendon. Again, it's important to remember when you're looking at dark white objects, how do you know this is a calcific deposit? Well, this principle of acoustic shadowing. So our ultrasound beam is coming from the top down. When it hits something like calcium or bone cortex that it can't go through, the beams are returned back to the probe, and we're going to see a dark shadow behind it. Next, we have plantar fascia. When we look at the plantar fascia, again, upper left, we have usually I'll often start the patient face down, foot hanging off the bed. The heel skin is often very thick. An important thing to know when you're scanning the plantar fascia is often you have to turn the gain up on your ultrasound machine, right? The gain is what increases the brightness of our picture. So we can see some of the deeper things on the foot looking through this very thick heel skin. We are orienting our probe in long axis with the plantar fascia. Here's our 3D view again that shows the probe. We're seeing part of the calcaneus and the plantar fascia, different than when we're looking at the Achilles. We have the plantar fascia coming off here, and here's our ultrasound view. So here's the bottom of the heel. This is the fat pad of the heel as it's labeled here. Here's our calcaneus, and this structure coming across left to right is the plantar fascia. This is heel here, and these would be toes out here. And this is a normal plantar fascia. When we get to abnormal ones, for those of you who haven't looked at a lot of plantar fascias by ultrasound, it becomes painfully clear very quickly why plantar fasciitis hurts. This is the ground that you're walking on. A normal plantar fascia peeks out onto the calcaneus nice and cleanly. And this thickness typically is less than about 0.4 centimeters or 4 millimeters thick when we measure it. Now, when we start looking at some of the more pathologic plantar fascia, again, same view, long axis to the plantar fascia. I'm going to start you actually down in the lower right corner here, if you can see my mouse. This is a split screen of a left and right foot for the same person. So again, calcaneus, long axis to the plantar fascia. You can see the plantar fascia coming in, and even this one is thicker than that initial view I showed you. But look how this compares to this. Look at the thickness of this plantar fascia. Remember what I told you. This is the ground. This is your heel pad. This is the marble that they're walking on all the time that's causing them pain. You can see real quickly why standing on your heel, here's the bone, here's that nub of tendon that they're constantly walking on can be uncomfortable. Those patients that come in with that sudden tearing pain in their plantar fascia, here's that same view. Here's calcaneus, here's fat pad. Here's a large black space where the plantar fascia should be, right? There's no organized structure tendon coming across here. When we look over here, this is plantar fibromatosis. So here's the plantar fascia. It's a nice, thin, fairly regular-looking plantar fascia. But these are big fibromatous nodules that sit right on the plantar fascia. Very different problem than plantar fasciitis, difficult to treat, and something, again, distinctly different. Without looking, sometimes it can be hard to distinguish if you can't feel the nodules. Plantar fascia injection. This is an injection talk as well. So how do we inject the plantar fascia? Well, I find there are two ways, like I said, to inject anything. We can look short or long to the structure that we're talking about, the plantar fascia, and then we can inject short or long to that structure. And this picture here is a short axis view of the plantar fascia. And sometimes when we have a hard time delineating exactly where the plantar fascia ends and fat pad starts, we can use that same anisotropy or tilt of the probe to help better define the borders of our structure. And then we can come in, this is from a medial to lateral approach. Here's a long axis approach. So our probe is oriented short axis to the tendon, and we are going to do an in-plane or long axis injection to the deep aspect of the plantar fascia. You know, one of the risks when we talk about steroid injections into plantar fascia that I'm sure many or all of you have seen is that patients who's had multiple plantar fascia blind injections and they now have no fat pad. So as you come in here, what we don't want to do is inject steroids up high here into the fat pad. And afterwards, we can pull up a picture if you want to see of the long axis injection. The other way to do this is looking long to the plantar fascia. Let me go back for a second. We can look long to the plantar fascia. Our probe is oriented this way. And now we're going to come in out of plane or a short axis injection, injecting right down here to the deep fibers of the plantar fascia via short axis. Now the difference is, this is our view. All we're going to see that appears is the tip of our needle. So if as we're injecting, the tip of our needle appears up here, right, that's in the plantar fascia, that's in the heel pad. We don't want to inject that. We want to be down here into the deep pathologic aspects of our plantar fascia. All right, we're going to move on to ankle tendons. So we have medial and lateral ankle tendons. The peroneals are the two tendons that sit on the outside of the ankle. Again, as we're scanning, we're going to scan just posterior to the lateral malleolus, and we're going to scan as best we can in a short axis to the tendons as they come around the lateral malleolus and continue on down to the foot. You can see here, here's our 3D animation view where we can actually see we're looking from lateral malleolus around, and we will catch the peroneus longus and brevis as it comes around the back. When we look at our structures here, here's our lateral malleolus, and outlined here is our peroneal brevis, longus, and the muscle belly of our longus. So as we come down, remember the brevis is already tendon, longus is still tendon and muscle, and you can see these three right here. We're going to look at a little bit of pathology here, and this is a real interesting slide. So this would be peroneus brevis and longus, and this is actually a split tear in the brevis where you can see the longus that actually is kind of interdigitating between the two. This is our drawn-out view so you can see exactly which structures we're talking about, but if you watch this video over here, it plays a little bit in reverse, but you're going to see this is longus pushing through and then coming back out. So here's brevis, and watch now it's within the brevis and it comes back out. And so as they kind of circumduct the ankle, moving back and forth and move the longus and brevis, and this is the same thing we're going to look for when we're looking for peroneal tendon subluxation, we can see the brevis and longus, or the longus rather, splitting the brevis. Hold on. All right, so here, let me get this to play. We have a peroneal tendon subluxation, so we're going to look at the same view. We're looking laterally, short axis to the tendons. You can see this moving back and forth. This is how we're going to get the ankle moving. And this is a frozen picture right as the tendon sublux out. So here's the brevis, longus, and the muscle body as they come from where they used to sit underneath the retinaculum, coming up and over the lateral malleolus. And here's a dynamic video showing a patient of mine who, as she moved her ankle, you can see the peroneal tendons pop right up over the top and right back down. So they pop over the top and back down. And there's two kinds of peroneal tendon subluxation. This is the more common kind where they're actually subluxating out of the groove. There's a second kind of subluxation where you actually just see peroneus brevis and longus switch places, where they're switching or subluxating around themselves while still in the sheath. So just because you can't see or feel the tendon snapping over the groove, don't assume that you don't have a peroneal tendon subluxation problem. This is fluid as we track down when we're looking at fluid around the peroneal tendon. You can see in a dynamic view scanning cranial to caudal as we go down, fluid tracking all along the perineal tendon sheath. Again, here we switch to a long axis view of these tendons. You can see probe orientation, perineal tendon, a normal tendon. The sheath here, no black fluid within there, and you can see this abnormal tendon with fluid tracking all the way down and around the perineal tendon. As we move from lateral ankle to medial ankle, all right, hold on. It looks like I've been told we still can everybody see medial ankle?
There we go. Now it just popped up, Dr. Berkoff.
All right, we had a little screen lag, I gathered there.
We're in good shape now. To your mouse moving. We're good.
We're good? Okay. Apologize for that. So when we look at the medial ankle, these are the mnemonic Tom, Dick, and Harry, and a very nervous Harry. So these are the structures, the medial ankle. You have We have the posterior tibialis tendon, the flexor digitorum. You have your flexor hallucis longus, which is real posterior, and then you have your vein, artery, and nerve that sit right in between here. It's important to understand this anatomy in part because these are common ankle tendons to give you problem, posterior tibial tendinopathy and tears, and also that the FHL tendon can be difficult to see as it's far around the corner and buried deep underneath all these other structures. So knowing where everything is, obviously knowing your anatomy is the first most important part. Here's posterior tibial tendon, here's flexor digitorum, here's your nerve, your medial and lateral branch, you have your veins and arteries, you have another little branch, calcaneal branch of the nerve, and then here's your flexor hallucis sitting way around the corner, so from front anterior to posterior. When we look at FHL tenosynovitis, so here's a normal scan. Again, this is a lot like the picture we just showed you, posterior tibial tendon, flexor digitorum, and the FHL. Here's an abnormal scan. So here's our FHL, but here's fluid tracking all around that FHL tendon. Remember, the FHL is going to hang around real posterior, head subtalar, and heading on down towards the big toe. We can see an effusion around the FHL. Again, normal. Here's another image with a ton of fluid around the FHL tendon, things we would have a very hard time picking up on physical exam. It's often very posterior, easy to confuse with sometimes a retrocalcaneal bursitis. When you throw the ultrasound on here, this is very easy diagnostically to see and separate out. Here's a short axis view with fluid, and here's a long axis view with fluid tracking along it. When we look around at the subtalar joint level, when you squeeze the arch of the foot and hold pressure, we can squeeze any fluid that may be on the plantar aspect of the tendon up around the ankle. And you can see here dynamically as we squeeze, fluid appearing around this tendon in the long axis. So we have a long axis view of the tendon. We're compressing the foot distally and watching this fluid reaccumulate. And you can see this again along the plantar aspect as well dynamically. When we squeeze and release, we can see fluid tracking down along the FHL tendon. When we look a little anterior at the medial ankle, now we're looking at the posterior tibialis tendon. Again, it's that first tendon that sits here underneath the medial malleolus. Here's the tendon. Here's an abnormal tendon, and this is a patient of ours scanning cranial to caudal again, and you can see as we start up high, it's a fairly normal appearing tendon up here. As I scan more distally, you can see a large defect in this posterior tibial tendon. So again, it's a simple scan. We're looking short axis, and I find in general the short axis views are typically, to me, the most helpful when scanning tendinous structures. We'll still look long axis, but I prefer and find it easier to identify pathology often in the short axis view. So how do we inject the posterior tibial tendon? Well, any long tibial tendon structure, there's a tendon in the sheath. We can get to it via an out-of-plane short axis injection or an in-plane long axis. So here is viewing the tendon in short axis. and this is an out-of-plane or short-axis injection. Our probe is held where this green bar is. Our needle is coming short axis to the tendon, coming straight down through the skin here. We're going to aim for not the center of the tendon, right? This is a round structure, so as the round structure curves away, there's always a little gap or space here next to the tendon that we can see is an easy spot to get the needle into. So as we see tendon here, we're out of plane, and if you watch right down above my hand here, you're going to see tip of the needle appear. The hard part for most people is you have to know where the tip of your needle is before you start to inject. And the key to an out-of-plane injection is, here's my needle. When my tip appears underneath here, I see a bright white dot. If my tip is all the way
Dr. Berkoff, we've got your audio is muted, it appears. Dr. Berkoff, I don't know if you can hear me, but we've lost your audio. Can everybody hear my voice? Okay. Got a couple confirmations you can hear my voice. We're not hearing Dr. Berkoff's voice. Getting lots of confirmations that you're able to hear my voice, Daniel with Sonosite's voice, but not our host, which is Dr. Berkoff. Okay. I just got confirmation from Dr. Berkoff. I just dropped him. If everybody will hold tight while I conference him back in. One sec, guys. Okay, we're in good shape. Dr. Berkoff, we've got you back on the line. If everybody in the chat window could confirm that you do hear us. Dr. Berkoff, can you hear me? There we go. Dr. Berkoff, can you hear me?
Okay, I can hear you. Can everybody hear me?
All right, we've got confirmation. We hear both Dr. Berkoff and myself. Let's get this show back on the road so we can hear it.
I apologize to everybody. I guess I was pushed to the side. I'm not sure where I lost you, so I'm pretty sure everybody heard us talking about the short axis injection out of plane, looking short axis to the tendon. Dan, can you confirm you still heard me on that?
Absolutely. I got you on that short axis injection. Now I think the next step, I believe, would be that in-plane short axis.
Perfect. So now what we're going to change to is the other way to inject. And again, keep in mind, really superficial structures, right? Here's malleolus, here's the skin here. This is a few millimeters deep. So sometimes in thin, bony people, this can be difficult without the use of a big pile of gel, a standoff pad, or other things. But if you can get a nice, easy tract in, we are now looking short axis to the tendon again, short axis to the tendon, while we come in plane or long axis injection. And here we can see coming all the way across the needle tip coming down into the tendon sheath. Both are good ways to do this, and again, the most accurate way to inject a round structure like this, in my opinion, is to try looking at it in short axis. Part of the reason is because as we look long, here's a long axis view of the posterior tibial tendon. There's a needle coming in injecting long axis. We have to be very sure this is the tendon we're talking about, and this stays directly over that. We have multiple tendons all tracking similarly in a similar place, and if your probe starts to slide off that tendon, it's going to be very important that you know which tendon you're on when you come long axis to this tendon. Again, just to make sure everyone's caught up on the screen, we're looking here long axis to the tendon in an in-plane long axis view. Next, when we look at the anterior aspect of the ankle, or the anterior ankle joint, here's our probe. Here's the anterior aspect of the ankle joint, and this is how we can go about injecting it. Once again, this gets a little bit redundant. We can inject short or long to the probe. You can see when we look long axis to the probe, when this is sitting here, we often may run into bony structures or other things that can get in our way. A lot of this depends on the amount of soft tissue our patients have. When we look here, here's talus, here's tibia, here's the cartilage coming across on top of the talus, as marked in dark blue here, and here's our joint recess, and this is the spot that we're aiming for. Here's a little vein coming across the top, and these are important structures to identify, not just the target. And this is something when we teach our courses where it's real important. It's a little harder on cadavers when we're injecting in the cadaver lab, but as our needle comes across here or straight through here, not only do you have to know where you're going, but you need to know what you're going through to get there. And we don't want to cause any problems, issues, or other things as we go forward with our injections. So here's a nice picture of an anterior ankle joint recess looking in the same long axis view that we were looking before, and this is an in-plane or long axis injection into that joint space. If we were going to go short axis, our probe stays in the exact same position, and often the way I favor to do this is I'll put my probe directly on one of the tendons, preferably the anterior tibialis tendon. If I'm on the tendon, I know my needle has to come from the side because it can't come right where my probe is. I can't stick my needle in that tendon. So my needle comes from the side. Let me see if I can get this to come back. My needle comes from the side, and I can come short axis right down into this anterior recess here, this joint recess, without coming through all this other soft tissue. We're having a little delay. I'm going to try to go slow on the slides here just to make sure everybody's caught up. The last thing we can talk about injecting is injecting the MTP joint. I'll wait till this catches up. When we talk about any of the small joints of the foot, we pick the first toe joint as a good example of a small joint to inject. This same application can apply for midfoot injections, talonavicular, any of the other small joints, foot, hand, or otherwise. The MTP joint is a common joint to inject, and we'll talk about how to visualize it and the best ways to inject. Dan, can you confirm we are all caught up on the slides here, if possible? When we're looking at,
let's see, it's still switching over from the anterior recess. I think there's another slide click that happens here to the MTP.
All right. Well, I'm going to
You're
pause
sitting
for us. We're there
you're
now.
on the you're on the MTP joint on your screen, but right now it shows that you're clicking to the next slide. So it appears that we're probably five seconds back now. Let's see. There it goes. MTP joint. There's your anatomy on the upper left. You're in good shape. I don't know how live your mouse is.
So
you're pointing.
When we look,
yeah, good.
When we look to the upper left of the screen, we're looking at that first MTP joint, metatarsal phalangeal joint. We like to look at joints in long axis, looking across them. It's much more difficult to look at the joint with the probe turned 90 degrees scanning this way. When we look across the joint, this is what we see. Here's our metatarsal. This is our metatarsal head distally, and this is the proximal aspect of that phalanx. This is our joint space. Again, here's a little bit of the cartilage covering the metatarsal head, and here's our joint recess. This is what we're aiming for, to get our needle here to come in. Once again, and now you get to see what I mean by redundant, now we just have to choose if we want to inject long or short axis to this joint. Again, our decisions can be made by what other structures we don't want to stick a needle through, the size of the patient, where we're looking to get the best view, and how we best think we can get into the joint, causing the patient the least amount of distress. This is going to be a long, in-plane injection of that first MTP joint. So again, we are looking along the joint. Here's the distal aspect of the metatarsal. Here's the proximal phalanx. This is the joint space. This is coming proximal to distal. This is the tip of the needle as it comes along in plane, working itself right down into this joint recess. And as you see it fill, you can watch the fluid extend right down into that MTP joint recess. The other way to do this injection, hopefully we're keeping up here now with the slides, this is that same view long to the joint, but now instead of seeing the needle coming along, all we're going to see is the tip of the needle that appears right here and fluid tracking down. So once it resets, you're going to watch here and you'll just see the tip of the needle, two tips, that's the bevel, coming in this. This is a short axis or out of plane injection in the MTP joint. Again, the most important thing to remember on all out of plane or short axis injections is you not only need to see the white of the needle, but you have to know that what you're seeing is the tip of the needle. And the best thing I can say to use for confirmation is either the two-tip sign. If you see the tip and the bevel, that's obviously the tip of the needle, or you just give a little puff of fluid. If you don't see the black fluid appear around the needle, you're looking at the stalk of the needle and not the tip. And that's what we have. So those are some simple ways to inject some of the structures around the foot and the ankle. I find in general the most important part of foot and ankle is being able to identify structures and identify pathology. I think the injections for the most part are fairly straightforward. These are superficial structures where if you can identify your anatomy and know the pitfalls, know the bad things you don't want to stick a needle through, you can identify the safest and easiest way to do the injection, and you can proceed from